Thank you for coming. Our first speaker today is Dr. Jacob Dubroff. Dr. Dubroff is an associate professor of radiology and is modality chief, nuclear medicine imaging and therapy at the University of Pennsylvania in Philly. Dr. Dubroff is the current chair of SNMMI's Brain Imaging Outreach Working Group. Please welcome me and join me in welcoming Dr. Dubroff.
Thanks, Steve. Good afternoon, everyone, those of you in person and those online. I wanted to talk a little today about the science of PET and how far we've come from. So some of my slides have a lot of information on them, and there are lots of pictures, but I want to break them down in a way that lets those of you who aren't familiar with PET imaging to understand kind of how it works and where we've come from to come up with a lot of the tools that we use for diagnosis and now directing therapy for Alzheimer's and diagnosis of other dementias as well, because there's more to mention than just Alzheimer's disease. And there's really two components that's come from over the years that have changed a lot in my 2 decades or so of being in this field, and that's with how PET scanners work and what PET radio tracers we have. And both of these have gone leaps and bounds to kind of put us in the position today to kind of bridge gaps in patient care and understand disease in a far greater way than we have before. So the title of my talk, Art and Medicine, that talk appeared, so I said let's put some art in to help break this down. And so this is a very famous picture by Edward Munch, I think 1893. And a lot of the other modalities that we use for medical imaging have this exquisite level of detail. This picture isn't the most exquisite level of detail, but you know exactly what's going on with emotionally when you look at this piece of art. I mean, there's fear, there's terrifying, the same way it evokes a certain emotion. And I think the same thing will go with the more serene kind of Monet water lilies kind of puts you in a more peaceful place. And I think when I talk about image, we're going to talk about how the images are made, but I think there's a lot of information in these images that comes with the expertise of how they're developed and also and especially how they're interpreted. And just to give you a bridge to that, and that's how I look at a lot of medical technology, especially image interpretation. It's not just a matter of how granular the information is, but what is the message that the picture is sending us, and that's what we have to convey to really make a diagnosis and help, and it's helped us understand disease considerably. And so first we'll start with PET scanners. So a PET scanner, there's a gurney, there's usually a ring, and the ring is where all the magic for PET detection happens. And for those of us who have had a PET scan or have had a loved one had a PET scan, it's very much kind of been homogenized in a good way to what the patient experience should be. You're going to go to a reception desk, you're going to be taken back by a technologist, the technologist or a nurse or another medical professional is going to start an IV. They're going to give you a radio tracer. The radio tracer, you're going to sit in kind of a room for a little bit while the radio tracer distributes in your body, and then you're going to be brought into one of these rooms, which tend to be also very serene. We try to make it more water lily-ish when you're at his experience, and you're going to sit there, and the machine isn't loud like it is in an MRI machine, and we're going to take pictures probably from somewhere around 10 to 20 minutes. Your entire time in that room might be 30 minutes, and that's what it should be like. But there's a lot more going on for us to be able to take those pictures. Now, I know we used to teach, when my children, who are now, I have 2 teenagers, went through and learned about physics, and I was very excited for them to get physics, all the different types of energy that exists out there. And so while an MRI scan might operate, Gesundheit, might operate in kind of your radio wave, your infrared bands here, we're up here in terms of your X-rays and your gamma rays. And I have another picture I put on that. So MRI is kind of down here. X-rays, gamma rays, radioactivity. And although the energy waves get shorter, they have a lot more energy, and that's why it's radioactivity, and that's why we have to be very careful. But the amounts of radioactivity we actually use are extremely small, and they're not going to cause long-term damage by having an imaging study. Other parts where we actually use it for treatment, and there's parallel sessions, as you may be aware of, with radioligand therapy, and different types of therapy that we use those are a little bit more dangerous types of radiation. We have to be careful about how much we're giving because we want to minimize any type of damage we do to that patient, really treat the disease. Part of my practice is looking at patients and just looking at their images actually, and making diagnoses. So I don't actually interact with patients a lot of time, but a lot of my practice is also treating disease, and in this case, thyroid cancer. So this is an opportunity for me to actually talk with patients and entertain questions for those about Alzheimer's disease. But the interesting thing when I talk to them about nuclear medicine is that they didn't know nuclear medicine existed till they had this disease. The truth is nuclear medicine has been around since 1940, 1941, especially for thyroid. So we've been around for a while. And some of the stuff is the same as it was in terms of a lot of the theories and how we do things. I mean, we've gotten a lot better significantly, as I'll talk about in a sec. But it means it's really proved itself to be a very adaptable and very smart kind of science. And a lot of the people wandering around this conference today have a lot to do with that. So after you get, and this is another fancy physics diagram, so don't be intimidated by it, there's not a test afterwards, the technologist will inject you with this radio tracer, as we call them, and the radio tracer is going to distribute in the body and kind of settle in a location. And once it settles, once it binds there, it's got a positron, but the positron, we call it positron emission tomography, it is actually the opposite of an electron. It is a positively charged electron. Almost exactly where that positron was, it immediately disintegrates into two electrons that go in opposite directions. And that allows our PET technology to detect it. And not just, this is just a two-dimensional representation of the brain, but we put them together and we make a three-dimensional representation of the brain. One thing that has changed is you can see the quality of the actual pictures has gotten a lot better over time because we have a whole section here on physics and instrumentation who work on how do we make better scanners. One of the new development scanners is scanning technology tends to be very hard to calibrate and also is very sensitive and expensive. So we don't want to have, we work in a capitalist society, so we can't make huge scanners that cost a huge amount of money unless we can justify how they work. But what we've discovered is that by making these scanners a little bit longer, instead of a gurney that might be 20 centimeters, a little short of 2 feet long, we now make them very long. And these are more expensive scanners, but we found we can scan people with we can see things better, and we can also scan people faster. And that's the latest technology that's happening. We still have plenty of really great scanners that stay in one place. So if we're scanning someone's whole body because they might have cancer that moves over them. But this is just a diagram of a person showing how we can pick up more of these anti-parallel, these electrons going in opposite directions in many different planes, allowing us to have better scanners. And this is just an example of one of these scanners was adapted at my home institution here, and this is kind of the first image from that. On top of that, another thing you may not know about scanning technology, it has been a huge deal also in this society as the folks in collaboration with a company, Chinese, and at Yale University, and also at University of California, I think Davis, they have this collaboration to build one of these scanners, but specifically for brain. And they are seeing details that they've never seen before of the human brain. This is a publication that came out this past year that actually I was just at the editorial meeting, won paper of the year for the journal for the society. And this image actually a year ago won image of the year for society, which is a big deal. I mean, there's thousands of people here that's submitting a lot of different stuff. And it just shows us, without getting too neuroscience-y and detailed, the level of detail we've never been able to see before in the human brain using PET. And it's not going to get worse. It's going to continue to get better. And so we've talked about instruments. We've talked about how much better our scanning technology has been. But now we need tracers, right? You can't have a scanner and not have any reactivity. The PET scanner is essentially a very fancy radiation detector where we're looking at how this radio tracer is distributed in your body. And one of the mainstays, and has always been, if you look just in 2010, there was really only one radio tracer 15 years ago that was good for a brain, and that was called FDG, fluorodeoxyglucose. And if you look at these again, don't get too intimidated by this. There's no test. This is just a structure of the molecule of what it looks like. And so this is actually glucose. This is a glucose molecule right here. And the fluorodeoxyglucose molecule is just, this oxygen hydrogen group has been removed, and they've put a radioactive fluorine 18 group there. And that is what is ejected for an FDG scan. So it's essentially a sugar scan. Now, the first kind of FDG glucose scan was done also at my institution years ago, and there's really not a ton of level of detail you can make from these scans. And even 3 years later, they made a publication, and this was hot stuff in the late 70s. You can see where they've tried to superimpose the anatomy and what the glucose map looks like back then. And that's not good enough for us to make a diagnosis. However, as I said, scanning technology has come a long way, and this is an image that I had for a publication a couple of years ago, and it just shows this is a normal on the left side, and there are different subtleties where you see the red is, I would say, more normal glucose utilization, the highest in the brain, where you start seeing these gaps here. There shouldn't be green here. There should be all red, or here also, and maybe a little bit down here. And this one here, it's also back, but why is this area preserved, right? And then on the other side, and this pattern is more of an Alzheimer's pattern. This is what we call Lewy body dementia pattern. And these two, you see the decrease in the front part of the brain. This is where horizontal axis in the brain. There's less metabolism, and that's more of a frontal temporal dementia. All these can occur. So what's been happening with radiotracers? This is our only tool, and this was a very helpful tool, and it continues to be a very helpful tool for neurologists and geriatric psychiatrists and people who diagnose memory disorders. But in 2015, we had 3 of the amyloid tracers that were developed. Well, how do these work? How did we get to these amyloid tracers? Well, to actually describe how Alzheimer's disease progressed and occurred, it used to only be post-mortem, and people would generously donate their brains, and scientists, this very famous scientist pair, Brock and Brock, looked at the spread of amyloid and also tau on the right, and they staged disease. Severity is going down, and they saw that amyloid, in the gray and black here, kind of the worse, the more amyloid, and they graded that higher. But tau existed and had a more limited range relative to that. And that is because they looked at it under a microscope. And on the left here, you see what neuropathologists look like in terms of this is the amyloid plaques, and these are the tau tangles. These occur outside the cells and the neurons in the brain, and these occur kind of inside. So how do we detect those? So it was very straightforward. Again, no test on these molecule structures, right? But what I want you to see is just see how see this flyofavin T and the Congo red? Those are actually the dyes that the pathologists use to detect the amyloid. All right? And so what we did, and what a lot of radiochemists did, is they attached radioactive particles to a part of the actual dye to make them radioactive. So they would stick to where the plaques were, and then they'd give off a positron, which in turn we could detect with our PET machine. All right? So 5,5-T looks very much like this commercially available flutometamol, and then Congo red looks very much like these florbetapir and florbetapen. These are 2 other amyloid tracers that are not really available for different reasons. We might actually eventually see this one. This was the original one. You see the C11 instead of the F18. One of the nice things about F18 is that it is a 110-minute half-life. That means it gives us kind of a nice range to inject and then put a patient on the PET scanner to image them. C11 only has a 20-minute half-life. Very hard to deal with any patient, let alone someone with a memory disorder who can't get around as well, to give them an injection and get them on the table and take good pictures. So we like F18 tracers better. Well, how do we prove these F18 tracers work? Well, this study, along with other studies like it, where we had to look at PET images and we had to look at the pathology right next to it. So, and how did we do that? Well, we had a group, this paper was almost 15 years old now, two groups of 30 patients. One where they clinically had a diagnosis of Alzheimer's disease by an expert, a neurologist, a geriatric psychiatrist who could diagnose them. The other was a group of patients who had some type of end-stage disease, that is a disease that they would eventually, they could not survive from, so maybe heart failure and they couldn't get a transplant, or There's a number of them out there, and getting specifics, but basically they agreed to have a PET scan and then generously agreed and thoughtfully agreed to donate their brains for the pathology study. And so we were able to look at the PET scan and say, hey, what does that PET scan look like? And then here's a piece of their cortex, and you can see in this person who didn't have a diagnosis of Alzheimer's, then didn't have any staining, this brown stain for amyloid plaques, and here they had a bit more. You see the nice rainbow colors on this little bit of the red and the yellow, and they had more plaque, and then here much more on the PET scan down here, and then many more plaques. So that's how we proved our PET signal was actually looking at amyloid. And then we were able to, these are the 3 commercially available ones, and the year they were approved, and you see the positive scans, they're in different colors because the companies want to differentiate themselves from each other, but positive versus negative, positive versus negative, positive versus negative. So someone like me who interprets PET scans can say that one's positive, that one's negative, and then that can be relayed to help diagnose, or in this case, we've seen treat disease. Since then, there's been a number of these other tracers. So since 2015, we had the 3 amyloid tracers. These other tracers have been approved by the FDA since that time. They don't have the same implications for neurodegenerative disease, but at the same time for Alzheimer's specifically. But at the same time, look, there's this increase in radio tracers that are being developed and available to the public for allowing someone like me to help clinicians diagnose disease. And then most recently in 2020, FDA approved flotowsapir, which actually looks for tau. Again, there are your plaques and there is your tau, so this is the other part. And that's what a positive tau image looks like. There's a negative one on your left and a positive one on your right here. And even then, this year, this is actually another looking at other tau tracers and comparing them to each other only in brain sections, and I think the next step is to actually look at these in patients, is which is the better tau tracer, which tracer can really let us know what's going on. So I will tell you, we're still developing those tracers. Finally, there's other developments of other different proteins that accrue in different types of disease, and there's also this phenomena where there's different dementias that overlap. It's mixed, and so that person may have a couple things going on, or they may not be a good candidate for one type of therapy. Specifically, everyone is very interested in the anti-amyloid therapy, which has been just really incredible to develop in the last couple of years. And so one of the tracers many labs are looking at, including one at my institution, and this next picture is not from them, but it's this compound called alpha-synuclein. So that can occur in Parkinson's disease, but other types of dementia as well. So I think we've seen the development of the instrumentation, we've seen the development of the radio tracers, and so I think, we can conclude that PET tracers have really dramatically improved over the last 40 years, and PET radio tracer has also, and that instrumentation radio tracers have synergistically accelerated PET neuromolecular imaging. They work together. It's not just one thing getting better, but we're seeing so much more. And I think these advances have directly affected the diagnosis and treatment of Alzheimer's patients. And we see that today, and I think we'll hear more about that. So that's the end of my presentation. Hopefully I've taken some of the mysticism out of PET scanning and made it a more practical, real thing, but it's come with tremendous work by a lot of people who are actually at this conference, and I think we're just worlds away than we were even a decade ago. And I really, I hope this was helpful, and I guess you're gonna introduce Anne, but thank you for attention to this talk.